Hello, everyone. This is Katie Weary. I am the Director of Operations Consulting with Healthcare Provider Solutions, and I will be your host for today's webinar. Our topic for today is Hospice Regulatory Necessities, CTI, Election Statement, and NOE. Just a few housekeeping things that we need to take care of before we begin our session. I want you to know that if you have any trouble whatsoever from a technical perspective with this webinar, you have two options for resolving that. You can contact Drew Raleigh at our office. His telephone number is 615-399-7499. Again, that is 615-399-7499, and you want to ask for Drew Raleigh. You may also email Drew for today's session at drowley@healthcareprovidersolutions.com. Again, that's drowley@healthcareprovidersolutions.com. We are recording the webinar today, and an email will be sent letting you know how to access the recording shortly after the webinar. After I complete the presentation, I will have a session for Q&A at the end. At that time, you will hit *6 on your keypad to ask a question, and you'll be submitted to the queue. Also, you can use the chat feature to contact Drew. That was one thing I did not state earlier. Want to make sure you know that. So you really have three options: telephone call, email, or the chat feature on your screen. And again, we're recording. You'll get an email about that. And at the end of the session, I will open it up for Q&A. Well, let's go ahead and get started because we have a lot to go through today, actually, in our 90 minutes. And I want to start really with the background about our topic that we chose for today. We chose the topic, and specifically the CTI, the election statement, the NOE, and the plan of care, because these items are required not only for compliance with the Medicare conditions of participation, but also for Medicare payment. These are the items that every single patient must have, or that must be on their record, in order for Medicare to pay the claim. And that is regardless really of who is reviewing the record, whether it's Medicare, one of their contract auditors like the RAC, CPIC, UPIC, the Medicare administrative contractor for an ADR. These items are absolutely necessary, and they'll be reviewed each and every time that record is reviewed by Medicare or one of its contractors. However, these specific items that we're going to talk about today are singled out in different ways by various governing and oversight bodies such as CMS and the Medicare survey entities now, which is new, and also by the OIG. The OIG is the Office of the Inspector General. So in addition to conditions of participation and payment that have been in existence for many, many years under hospice, we have something new called Targeted Probe and Educate. And this particular method that CMS is going to be using for medical review brings to light, again, the need to have these documents in proper order and in proper form. So we'll talk about those two components. There's been some OIG reports that have addressed the impact of not having the election statements and the CTIs the way that we need to have them. And the Targeted Probe and Educate and the Medicare certification and recertification surveys are new. I'll talk more about Targeted Probe and Educate as we go through our session today, as I will also address the Medicare certification and recertification surveys. So the items we're discussing don't impact just compliance. When there is something wrong with these items, it does slow down payment. Either we have to appeal to get payment, or we're waiting quite a while. Even with an appeal, we're waiting quite a while to get payment, and we don't have the opportunity, once a reviewer looks at these documents to really go back and correct them. And I'm concerned that some of the election statements and the CTI forms themselves have been the reason for denial. Now, that's going to impact every single patient. It doesn't matter what's on the physician narrative if the CTI form itself is not accepted. And again, that impacts every single patient. So this is a widespread or potentially a widespread issue. So we're going to talk about all of them, how they impact our cash flow, what we need to do to ensure that we have the eligibility requirements, the technical requirements of each of these items in place. So every single patient, as I said, and every single claim, and I should clarify that I'm talking about every single Medicare claim, needs to have these 4 items that you see on slide 4 in order to be fully reimbursed. So that means that the certification of terminal illness has to be there and it has to be correct. The valid election statement has to be present. The notice of election has to have been submitted timely and accepted. And we need to have a plan of care. Those are the items that, according to Medicare and the Medicare Benefits Policy Manual, states that we need to have in order to be paid. Now, I do have here that we have to participate in the Hospice Quality Reporting Program, and while non-participation will not result in denial of a claim, it does result in a 2% financial payment penalty. So I did mention that as well. In order to receive full payment, you need 5 items here, and that includes the participation in the HQRP. But the record, when it's reviewed, all 4 bulleted items there at the top are going to be reviewed. Excuse me. Now, the hospice does not submit all of these documents to Medicare when a claim is submitted, but Medicare requires that the items be in the patient's record to support the claim should they ever request to see that. Now, there is one exception, and that is the notice of election, the NOE. The hospice does not actually can keep this in their record. It's something that is submitted to Medicare. This is where we go into the DDE system, or recently, in some cases, we can begin submitting the notice of election electronically, and we'll get into those details later on in the session. But all the rest of the items are maintained in the patient's record, and the hospice has to have them ready and available to submit to CMS or its contractor if they request that. Let's go ahead and take a look at each of the requirements. We're going to start with the CTI. Now, the certification of terminal illness is fundamental for the Medicare hospice benefit. Medicare is relying on physicians to determine if the patient electing the Medicare benefit indeed meets the requirement of a 6-month or less life expectancy if the illness runs its normal course. There is an eligibility component, which is the physician narrative component to the CTI, and we look at, not we, but the Medicare reviewers will look at whether or not that supports the patient's terminal condition. And then there's also the technical components. The technical components are contained on the form itself, items such as whether the attestation is present, if it's in the right location on the form, and the timing of the form, physician's signature on the form. We're going to go through all of that. The point is the CTI is complex, and it may seem as though this is a very elementary topic, but the number of denials because of not having items correct, especially on that CTI and the eligibility statement, as well as the technical component, definitely indicates the need to have some discussion about this. And don't take your form for granted. As I go through some of the concerns about the CTI and we get into the details about the form, take that, go back, actually look at your form. You'd be surprised at how many forms don't actually meet the requirement. But I wanted to start by talking about some of the CTI concerns, because there's been a renewal, I should say, in the attention that the CTI is getting fairly recently. Now, the OIG, the Office of the Inspector General for Health and Human Services, released a report titled Hospices Should Improve Their Election Statements and Certifications of Terminal Illness a couple years ago, actually at the end of 2015, I believe, going into 2016. They released that report, and they found that the foundation supporting the claim, the CTI, was lacking. They also found that the election statement was lacking in its requirements as well. We'll talk about the election statement a little bit later, but one of the findings about the CTI in this particular OIG study was that the physician seemed to have limited involvement in determining that the beneficiary was appropriate for hospice care. Now, we have a requirement currently and have had it for quite some time, since at least 2008, I believe, or 2010, and that requirement is that the medical director has to consider 3 items when making the determination about certification, and those items are the diagnosis of the terminal condition, other health conditions, whether or not they're related, and current clinically relevant information supporting all of the diagnoses. Now, the physician narrative on the CTI is the evidence that the medical director has considered all of those items. And we have seen numerous denials of claims because that physician narrative on the CTI does not support a terminal prognosis for a hospice patient. And it's because we are seeing those denials, and in fact, it's the #1 denial reason below hospices not turning in records when an ADR is requested. That actually is the #1 denial reason for most of the MACs. But right below that are denial reasons related to this narrative on the CTI. So because of that, CMS started to look at that current requirement, and they acknowledged that the source of the clinical information to be used by the certifying physicians is not clear in the requirements. It just states that the physicians need to use that. And again, they're looking to the narrative to prove that the physician has used that. They're looking for some, and I'll go back to that slide so you can see those 3 items again. They're looking to see not just that the diagnosis of the terminal condition is listed. And by the way, if your physician does list the diagnosis in the narrative on the CTI, make sure to include all diagnoses that are impacting the terminal condition. We actually don't recommend a list of the diagnoses in that narrative. What we recommend is that the physician state the diagnoses and state the other conditions, whether they're related or unrelated, in the physician's narrative. But anyway, CMS is looking at that narrative and in the medical record to see that the physician has actually looked at those items. And because those narratives don't make it clear that the physician has, they started to consider what could CMS do better in helping hospices to have better physicians' narratives, and they decided or questioned whether or not that would be providing some detail about the source of that clinical information. So they acknowledged that they didn't have that written, and it raised the question as to what clinical information the physicians are using at all to support that certification. And it caused CMS to consider changing regulations to specify that the source, excuse me. So as I was saying, it caused CMS to consider changing regulations to specify the source of the information and to require that a hospice obtain it prior to admitting the patient to hospice. Now, again, I want to be very clear. CMS just started to consider whether or not they should make some of these changes. And we talked about that in our fiscal year 2018 final rule and proposed rule in some of our blog articles and some of our previous webinars. So just to summarize what CMS considered doing or sought comment on from key stakeholders was to amend regulations to specify that a referring physician and or a acute or post-acute care facility record would serve as the basis for initial hospice eligibility determinations. So in other words, they would require that either an acute or post-acute care facility medical record would state why a patient, excuse me, would state why a patient is eligible for hospice services, or the referring physician's record would have that information in it, and the hospice would have to rely on that in admitting the patient. They also considered amending regulations to specify that documentation of an in-person visit from the hospice medical director or physician could be used as documentation in cases where the clinical information from the acute or post-acute care facility or the referring physician was not available or sufficient. So that would require a physician visit on hospice's part. So CMS did not propose a change. They're just considering that and asked for some information or feedback from key stakeholders about that. They then went on to say that they would be working with the Medicare administrative contractors, that's CGS, NGS, and Palmetto, to confirm if they are requesting comprehensive clinical information as part of their medical review. And if they're not, answering the question, should such information be included in the ADRs? We know from experience that some of the MACs are not routinely looking at that information, and they don't specifically request it in the list of items to include in response to an ADR. So CMS is working with the MACs on that. We've not heard anything more about that recently, or very recently anyway, but we can expect that CMS will, because of their pressure, result in having the MACs probably add this to the list of items that they're requesting and look more closely at it during medical review. So then after some of those questions came about, there was a reminder to hospices to comply with the requirements, and that came in the form of the re-release of 2 MedLearn Matters articles. I have them listed here on slide 9 for you, 1628 and 1631, and I have links at the end of the presentation. And if a hospice did not know exactly what it should be doing, the MedLearn Matters articles directed the hospices to that 2016 OIG report that I referenced earlier about changes that need to be made to the election statements and the CTIs. And they also directed hospices to the CMS Hospice Payment Systems booklet, which is a publication that you can go out onto Google and download. It's very easy to find, and it's also linked directly from these MedLearn Matters articles. So CMS is pretty serious about this. The fact that they're now sending out a reminder indicates that they're getting ready to do some assessment of compliance, and they want hospices to be as prepared as possible. I know that sounds strange, but CMS really does consider that when they're going through this process, and they sent that reminder out really as a warning. This is really important. You need to pay attention to this, and then that's usually followed with some sort of actual compliance assessment. Now, we are thinking that this targeted probe and educate method that we've talked about before that the MACs will be using is going to highlight any problems in the CTI as well as the election statement. But the CTI is going to be reviewed as part of every TPE review, even if that TPE topic is not anything related to the CTI. It's because the CTI is needed to support each and every claim. So we have this suspicion that with the targeted probe and educate pulling 20 to 40 charts from each hospice that it's targeting, it's really going to highlight the fact if you've got a problem with that form, you've got 20 to 40 charts that are going to be denied because you've got one technical problem with the form. So the importance of this cannot be understated. The OIG is going to be looking also at compliance with the CTI. In the OIG work plan, there's a couple of different areas where it's possible that the OIG might be looking at that, but they have a general area. I believe the title is something similar to that, looking at whether or not hospices comply with all Medicare requirements. At least that's the purpose of it. That's very, very broad. And they'll definitely take a look at the CTI. At least everybody fully expects that because they've done a report on how it needs to change and the problems with it. There's other CMS contractors, even with Targeted Probe and Educate, if a hospice is referred to further action, they could be working with a RAC or a ZPIC or a UPIC, and CERT contractors are still out there. So there's other CMS contractors that are going to be assessing compliance, and what's also new, as I said earlier, is that CMS surveyors are going to start looking at the CTI. Now, I often hear from hospices that say, why are you so concerned about our CTI? We just had a survey we passed with flying colors. Well, even if a hospice has had a recent Medicare certification or recertification survey without any deficiencies, the hospice cannot assume that its documents meet all of the technical requirements, and that's because surveyors have not in the past assessed compliance with those documents as part of every survey. It's only been fairly recently that they've been instructed to begin looking at those. Now, one of the recommendations from that OIG report in 2016 was for CMS to instruct surveyors to strengthen their review of the CTIs and also of the election statements. Again, we'll talk about those next. And CMS did in the fall of this year instruct their surveyors to start doing that on surveys. And specifically, we believe that CMS instructed its surveyors to assess compliance with the CTI as it is stated in the 3 L tags that you see listed here on slide 10. I've got the L tag listed for you as well as the actual citation from the CFR so that you can look those up. I'm also going to go through each and every one of those. So L667 is the standard that there be an initial certification of terminal illness, and this is taken right from the state operations manual. So surveyors were supposed to be looking at this before, but they didn't really have a strong focus on it, and they can only look at what's listed in that state operations manual or referenced in the manual. So they don't pull the Medicare publication for the benefit. So they don't pull that publication 100-02, Chapter 9. We refer to it as the Medicare Benefit Policy Manual. That's not something that CMS surveyors typically look at. Only if items in it are referenced as part of the State Operations Manual, as part of those L tags. So this is the first L tag that they'll probably take a look at. It's L667, and this is where it's very specific as to what the physician needs to consider when making their determination. So the guidance to the surveyors is that during their clinical record review during the survey, they should verify that that clinical information necessary for certification is present in the record. Does everybody have that? In many cases, we use our own comprehensive assessment. That is fine right now. I said earlier that CMS was considering some changes and maybe looking at referring physician records in the future to support terminal prognosis, in which case our comprehensive assessment would not be sufficient. And they specifically said they might consider, or they wanted feedback on. They didn't come out and say that they were making a proposal, and I keep stressing this because I don't want everybody to panic, but I do think people need to get prepared because I think this is the warning shot over the bow, and I've said that before. CMS is going to be very strict in the future about this CTI, where the documentation is coming from, and they did want feedback on what hospices thought and other stakeholders thought about having this clinical information contained in the referring physician's record or the acute or post-acute care facilities documentation. So definitely there might be a change. There might be a change. That doesn't, it's an oxymoron, but I believe there will be a change. Many experts believe that there will be a change. Exactly what it will look like, we don't know. But assessment of compliance with our current regulations is probably what CMS will use to determine where to go next. And if they're not seeing industry improvement, they will make changes. It's the same process that they followed in every other provider type. So make sure that you have, of course, your comprehensive assessment, and that it would support and contain the subjective and objective medical findings and enough information that the physician could use to make their determination about prognosis. In addition to that, we are also suggesting, because of CMS's consideration of possible changes in the future, that hospices start obtaining information, the clinical information, lab test, visit notes from their referral sources or from recent hospital stays or post-acute care stays that the patient has had. Start getting that information at the time of admission to help support that physician's narrative. So the next standard that the CMS surveyors will review is L668. And again, this also requires that the physician review the clinical information, and they're going to be looking in the record for evidence of that. That's pretty straightforward. And then that each patient's record must include the physician's cert or recert of the terminal illness. And then it goes on to state what that CTI has to look like. So you can see that there are some references that are not in the SOM that a surveyor could use. 418.25 states that the hospice admit the patient only on the recommendation of the medical director in consultation with or with input from the patient's attending physician. And that, of course, is if the patient has attending physician. So that's at 418.25. So in order for your medical director to provide a recommendation to admit the patient, they need clinical information. It is okay for the nurse to relay that clinical information to the physician, but they do need to have it. And then 418.22 is the technical components of the CTI. So surveyors can look at the timing of the certification, the physician's narrative, the fact that it's present, they can look at. They would not be making a determination of whether or not the patient is eligible for hospice care because it's not within their purview, but they can look to make sure that a physician's narrative is present. They can look for the sources of the information, the clinical information that is supposed to be used in that certification, and they can look at maintenance of the record. So let's get into those technical components. So the CTI is to be done at each benefit period. There are 2 90-day periods and unlimited 60-day periods. We have to verify the benefit period. And this is because patients only have one initial benefit period, and once a benefit period has begun and it is termed, that benefit period is gone, and we don't ever enter it again. And what happens is a patient sometimes will have received hospice care years prior to coming on to your hospice program. They fail to tell you that, they forget about it, don't think about it, you don't know about it, unless you go into the CMS system and look to see what benefit period they're in. Yes, I know sometimes that system isn't always correct, but if you print out your screen, do a screenshot of that verification and save that on each and every patient, you've got proof to Medicare, should there be a problem later on, that yes, I looked and it didn't tell me that this patient was had received hospice care previously. And the reason you want to know this is because your CTI requirements are different for each of the benefit periods. But again, it needs to be done for each benefit period. That is different than the election statement. The CTI has to be done at the beginning of each benefit period. And only physicians can certify the patients. It cannot be the nurse practitioner, even if the nurse practitioner works for that physician. There are specific requirements in actual statute that guide this and require that only a physician certify. So this has to be an MD or a DO. Now, the physician can obtain information to use in their decision from your nurses or from the NP, but those individuals cannot certify. Only the physician can certify. Now, I said earlier that each hospice beneficiary only has one initial certification of terminal illness. That initial certification of terminal illness may have occurred 3 years ago, or it may be occurring now when the patient is being admitted to your program. And that's why it's important to check the benefit period. Excuse me. Because the attending physician, if the patient has one, and your hospice physician has to provide the certification for the first time that the patient enters hospice care. If it's a recertification, even if it's 3 years later, only your medical director or your hospice physician has to provide that certification. But what you don't want to have happen is to assume that the patient had hospice care previously, or maybe they told you that they had hospice care previously when really it was home health, and you don't have both physicians certify that initial terminal illness. That's going to be a problem. You're not going to get paid. So first benefit period, which ties into the initial certification, requires 2 physicians. The attending physician, if there is one, and your hospice physician. If the patient does not have an attending physician, what happens? It's okay. Your physician, your hospice physician, or the medical director would then sign as the medical director, and in the blank on your CTI form where it says attending physician, your physician can sign there also, or a notation can be made that this is one physician, there is no attending physician. That is perfectly fine. A lot of times physicians don't want to sign twice. That's okay. Just fill in the blank. Whatever you do, don't leave it blank. It does have to be filled in. If the patient's chosen attending is the NP, that NP still cannot certify this patient. Again, only your physician can do that, and you would follow the same instructions I just gave you for that signature line. And this time you would indicate that an NP was chosen as the attending. Okay, now the time frame for the CTI also needs to be discussed. A written certification is required, and you can obtain that written certification within 2 days after hospice care has started. So that's 2 days after the beginning date. That means if you admit a patient on Tuesday, you have until Thursday. So it's the 3rd day of care, but it's 2 days after hospice care is initiated that you have to obtain that written CTI. And if you don't obtain the written CTI in that time frame, which is very difficult to do unless you've got some full-time physicians right there, you can then obtain an oral CTI. But again, the oral or the written has to be within 2 days after hospice care is initiated. And for recertification, it's within 2 days after the first day of the benefit period. Now, there are instances where we want to obtain that CTI prior to the start of the benefit period, and that typically applies to our recertifications. So we obtain or can obtain those recertifications 15 days prior to the recertification date. And we usually do that because we're discussing the patient in an IDG meeting before the actual recertification date. So you have 15 days prior to that recertification date. If it's the case of an initial election of hospice care, you can obtain the CTI 15 days prior to the election. It doesn't happen very often, but it is a possibility. You are allowed to do that. And then your written CTI has to be on file in the patient's record before you submit the claim. So if you are billing monthly, which we have to do in hospice, and you admit a patient on the 28th of the month, and you're going to be billing on the 2nd, that written CTI has to be in that patient's record prior to the 2nd of the following month when you're doing your billing for days 28, 29, and 30. So keep that in mind. Okay, now the verbal certification that you obtain is just a statement from the physician that, yes, this patient is terminally ill if the disease follows its normal course. The written certification is where we're going to see that narrative that explains why the patient is terminal. You do not have to have a verbal narrative when you obtain a verbal or oral certification. I do want to clarify that verbal certification is not a verbal order. And I want to clarify that because sometimes I've seen hospices hold up billing because they're waiting on that verbal certification to be countersigned by the physician or to be signed by the physician. If you have the written CTI, you do not have to have that verbal certification signed because it is not an order. You don't process it like an order. Now, if your system does that, that's one thing, but you do not have to actually have that signed before you submit your claim. It's the written CTI that you need to have. Also, anybody who is allowed in your state to accept an order can take a verbal CTI. In addition to those people, those are typically your RNs, right, who are getting your verbal CTI. But I bring this up because you could get your verbal certification at the time of admission from somebody or have somebody in your admissions office who is not a nurse take that verbal certification. It's not an order. It is not regulated by the rules surrounding who can take an order. Many hospices choose to continue to treat it like an order, and that's absolutely fine. I just want to clarify for you that that is not necessary if that makes your life a little bit easier. Okay, so the content itself. The form is not prescribed by CMS, but what is contained on the form and where it is contained on the form is prescribed. And that is something that, as I said earlier, take this information, pull out your CTI, and verify that this is present. You'd be surprised at how many hospices have, even sometimes with an ADR where their record has been reviewed, the reviewer hasn't caught it, but there is a problem with the content of the CTI, and then on their next review, it gets denied. They're very surprised, of course, because they've not had this problem before. So it is beneficial and should be part of your compliance plan to at least review this annually, just to make sure that there have been no changes made. Okay, so the CTI has to contain a statement that the individual's medical prognosis is that their life expectancy is 6 months or less if the terminal illness runs its normal course. Pretty straightforward. Usually don't have a problem with that because it's an actual pre-printed statement on the form. The specific clinical findings and other documentation supporting a life expectancy of 6 months or less are supposed to be there too. And really need to look to the physician to summarize those in the narrative, or at least make sure that these clinical findings, the lab results that you're getting, other test results that you're getting from other providers, the visit notes that are being used, any type of finding like that, you are either including it as part of the CTI itself as an attachment, or it is in the medical record. Now, I often get the question about, does it have to be part of the CTI or can it be anywhere in the medical record? I have never gotten a straightforward answer on that from anybody at the MACs or CMS. It depends on who I ask. And there is some discrepancy depending on which guidance from CMS you're looking at. There's not been a problem with it if it's in the record. There's not been a problem with it if it's attached. So one of the two has to be there. But the summary from the physician should include that, or those findings in summary form. But the actual documents themselves also need to be present. Of course, we have to have the signature of the physician, the date the physician signs, and the benefit period dates that the certification or recertification covers. Having numbers of benefit periods doesn't work. So if your form says benefit period number 3, that doesn't work. It needs to be the actual dates that the certification or recertification covers, beginning and ending dates. The signature of the physician. There's a lot of guidance out there on signatures. I'm not going to go into all of it. I will summarize it by telling you that it needs to be an actual signature. It cannot be a stamped signature. It is allowed to be a faxed signature. But again, no stamp signatures. Electronic signatures are fine if those electronic signatures are identifiable as electronic. Usually there's a statement that says electronically signed by, and then has the physician's name. Needs to have the physician's credentials next to it also, MD or GO. Has to have the date it is signed, and there are specific requirements in the manual for when the physician does not date it. If that happens, the hospice is not supposed to go in and date for the physician. The hospice is supposed to obtain an attestation statement from the physician that he or she signed on that particular date. Okay, now this brief narrative, which is a large part of the problem, it has to contain certain items, but there's also requirements on where it needs to be on your form. So it needs really to be identifiable on the form, and it needs to contain an explanation of the clinical findings that support a life expectancy of 6 months or less. If you have a document called your CTI that is 1 page, that physician's narrative needs to be on that 1-page form as identified on that page. It should state physician's narrative. If you can, most of the EMRs print it out that way, and then there's a box or some lines for the physician to write. Many hospices have the physician's narrative on another form. They've got something called a CTI, and it will have the dates of the CTI at the top. It will have the general statement about the patient's terminal prognosis. And then there will be another sheet of paper that contains the physician's narrative. If you have that second sheet of paper, you have to identify that as an addendum to the CTI. I have seen denials when the CTI is clearly titled and it has an addendum, but that addendum isn't clearly titled. Even if it's right behind it, reviewers will pass right by it, not acknowledge it. Make sure it's clear that this is an addendum to the CTI. Even if you handwrite it on there, it might not be printed by your EMR, that's okay, but don't submit that document for review unless you identify it as the fact that it is an addendum to the CTI. You want to make that very clear. Otherwise, if you don't, it's just like not including it at all in some cases. Now, I have seen reviewers who are a little bit more skilled and take a little bit more time, they will identify it and use it. So I have seen it slip through, but in many cases I don't. So make sure it is identified. And then if that narrative is part of the certification or recertification form, not a separate addendum, the narrative has to be located immediately above the physician's signature. Look and make sure that it's there. If it's an addendum to the CTI, then in addition to the signature of the physician on the actual CTI form, the physician also has to sign immediately below that narrative in the addendum. So there will be two physician signatures if you've got these on different sheets of paper, which is perfectly fine. Just make sure that it all is there. We've talked a lot, or I've talked a lot about the brief narrative today and what needs to be in there. Slide 23 acknowledges that. Slide 23 lists specifically what the manuals state need to be included. And the only item here that we haven't talked about, well, there's actually two, are the last two bullet points. And the brief narrative cannot contain any checkboxes or standardized language that is used for all patients. So if you see the same sentences from your physicians on all of the narratives, that would be considered standardized language. They need to be informed that that is not acceptable. Most of the EMRs will allow plenty of space for physicians to write more than just one statement and customize that statement to the particular individual that is being certified and incorporating those findings, the clinical findings that we referred to earlier. Now, in addition to those clinical findings that were stated earlier, if we are in the third benefit period or later, we are required to have a face-to-face encounter. We'll go through those details in a little bit, but that face-to-face encounter does provide information to the physician to be used in making certification decisions, and the physician needs to use it for that. So that narrative should clearly indicate that those findings are used, not just that an encounter has been completed, but that findings were actually used. Okay, there has to be a physician attestation statement, and it has to be based, it has to state that based on the physician's review of the patient's medical record or their examination of the patient, and you should identify which it is, whether it's review or examination. That is not specifically required, but we recommend that you identify that, maybe just by circling it or such, but you have to have that particular attestation statement. And then if a non-certifying physician or an NP is doing the face-to-face encounter, there needs to be information indicating that they are the ones who did that, and they've provided the information to the certifying physician. Now, this attestation statement must be located directly above the physician's signature and the date. And remember, I just said on the previous slide that we were instructed by CMS to make sure that our physicians are signing right below the narrative. So what you should see is a narrative, an attestation statement, and then the physician's signature. Okay, so the face-to-face encounter is required for the third hospice benefit period and any subsequent benefit period. It cannot be conducted more than 30 days prior to the start of the benefit period. Now, there are some exceptions, which I'll go through in a minute, but here's what I want to say about these 30 days. The physicians can provide certification of the terminal illness not more than 15 days prior to the certification period or recertification period, which is most likely the case. But they can conduct the face-to-face encounter 30 days out. If they do that, they cannot fill out the CTI until you get to that 15-day mark. So there's a 2-week window in there approximately where they can't fill out the CTI even though they've seen the patient. So just keep that in mind. I've seen that be an issue on some of the reviews. And again, the face-to-face encounter has to be performed by a hospice employee, either the hospice physician or the hospice NP. It is not acceptable to have the NP as a contracted NP. Even if the NP, again, works for the physician, the hospice still has to employ that NP, or the NP must volunteer for the hospice. Now, here are our face-to-face encounter exceptional circumstances for timing. For new hospice admissions, an exceptional circumstance may prevent a face-to-face encounter prior to the start of the benefit period. Again, this is for a new hospice admission, not a recertification. And if there is some sort of exceptional circumstance, it needs to be very, very well documented. And in that case, the encounter can occur within 2 days after admission. If the patient dies within 2 days of admission without a face-to-face, then it's deemed as complete. But again, that applies only in an exceptional circumstance case. I've seen hospices say, oh, well, the patient died within 2 days, so we didn't need a face-to-face. Not the case. You really shouldn't even be admitting a patient without the face-to-face once they've entered that third benefit period anyway. But if there is an exceptional circumstance, and typically these are more like items such as natural disasters, or you've only got one physician in your geographic area and that physician was not available because you're in an underserved area, something like that, or there's not an NP available. It is not when you're limited in the physicians and NPs that you have to do the face-to-face because they're all at a football game every Friday night. And I use this example because this has actually happened. There was a hospice whose medical director was also the team physician for the local high school football team. So every Friday night, he was not available. And when they would admit patients on Fridays, they would count those as exceptional circumstances. Well, it's not exceptional when it happens on every single instance like that. So remember, these need to be exceptional, and really it is those natural disaster kinds of things, or something like all of your physicians maybe and NPs in the area that can work for your hospice all being at a conference at a particular time. Now, you should have backup, and your backup should not be gone at the same time everybody else is gone, but we know how things work sometimes. But exceptional circumstance. Okay, I think I've talked enough about what that narrative needs to contain. And the face-to-face encounter attestation is different than the brief narrative attestation. So the physician or the NP who performs the encounter itself has to attest in writing that they had that encounter with the patient, and the date of that encounter needs to be present. If a nurse practitioner performed the encounter, the attestation must state that the clinical findings were provided to the certifying physician. Now, that's what the manual states. It's also the case that if it is a non-certifying physician who performed the encounter, you need to have the same attestation statement that the clinical findings were provided to the certifying physician. So pay close attention to this on slide 28 and make sure that you verify that that is happening. So this face-to-face encounter attestation has to, of course, have a signature, a date signed, and it must be clear that it is a distinct section of or an addendum to the recertification form. So again, here's where you should be titling your face-to-face encounter attestation. Most of the EMRs will do that for you. If you're still doing it outside of an EMR, make sure you identify the attestation statement and the narrative on the face-to-face. If your NP or non-certifying physician wants to write a narrative or a summary of what has occurred during the face-to-face encounter visit, that's fine, but that's not the brief narrative that the physician should be using. The physician who is certifying should use that information along with other information and summarize both in the narrative. Okay, so some common problems with the CTI and the face-to-face encounters. Illegible signatures and dates. And if you have such a situation, you either need to get an attestation or a signature log. We highly recommend signature logs. We have unsigned, undated documents. Again, hospices should not be dating. They should, if the date is missing, get an attestation statement. Oftentimes we see that initial certifications are not obtained from both the attending physician if the patient has one and the hospice physician. The same with the recertification. What happens is sometimes we'll see that the attending physician has done it, not the hospice physician. So that's the problem. And the biggest problem really, though, is the required components are not placed in the proper location or they are not titled properly and not utilizing the proper professional. Again, NPs have to be employed. There are no exceptional circumstances for that, no ifs, ands, or buts about it. NPs that you use for your face-to-face encounters must be employed. They cannot certify the patient. Only the physician can do so. And then pay attention to your time frames. Now, when you have a late face-to-face encounter, there are some things that you need to do that are very, very specific. You have to, according to the CMS manual, discharge the patient from the hospice Medicare system, but you cannot discharge them from the program. You still have to take care of this patient. You're still responsible financially for that patient. So you would do what I call an administrative discharge to discharge that patient from the hospice Medicare system. Then you readmit that patient once the face-to-face has been completed. And because you're doing a readmission, you have to get a new election statement signed and there has to be new assessments that are done. And all that has to fall in place timing-wise in order for it to be approved for payment. This is a big problem if you're not tracking your face-to-face encounter timeframes very, very, very closely, and along with your recertification dates to make sure everything falls into place. I've seen hospices who don't recognize that they're a day off on their face-to-face encounter for months. They have to go back to the actual time that that patient was supposed to be recertified, and that is the date that is used for discharging the patient from the Medicare system. So if it's been months and you don't find out about it for that long, you lose all that payment. So really have a solid process for tracking all of the dates. Okay, that is a lot about CTI. It has taken up, of course, most of our time today. I am going to go through the other components, but that CTI is critical. The other components are going to be a little bit more quick for us to go through, and we're going to go through next the valid election statement. Now, the election statement is different than the NOE. The notice of election is what we submit to Medicare. The election statement is what the patient signs, and the purpose is for the patient to actually make an election. That is required, and they should understand that election. They should understand the waiver component of that election. They should understand that they have a choice of attending physician, and they should understand that they have a choice of the effective date of the election statement. There's a lot of components here, and we're going to go through all of those components. All of them have to be present. And the election statements are the items that when I'm doing review, HPS is doing reviews, we find quite a few errors with these. Don't get caught really though, unless somebody like Healthcare Provider Solutions is coming in to do a compliance review or you have an ADR. Now they're going to be looked at, of course, when CMS surveyors are there, so that actually will help a little bit in preventing future issues, but we've really got to pay attention to every single component. I would summarize the concerns that CMS has with election statements is that they expect the patient will make an informed election, and it's the hospice's responsibility to inform the patient. Now, some of their concerns are what the OIG identified in their report. The hospices should improve their election statements and certifications of terminal illness. If you look at that report, there are some items in that report that are required by the OIG in the election statement that are not actually required. And I want to clarify that. If you do go and look at that report, some of the items that the OIG said was missing, in fact, one in particular is related to the discharge of the patient. there is no requirement that the hospice address the discharge on the election statement. And the MACs, upon review, and other contractors are not requiring that. But the OIG did have it in that report. So if you look at that report, I wanted to clarify that for you. But make sure everything else that is required is complete and accurate, because that's what the OIG said is not present, and that required information is missing. And again, the reminder to comply came out, same documents as for the CTI. Again, a link is provided at the end of the session. So now, who's going to assess for compliance? Exact same entities that we talked about with the CTI. New again is the targeted probe and educate. You're going to have a lot more records under review in most cases. So greater possibility for denial here if the election statement is not right. And CMS surveyors looking at this, it's something that's new. There's only one LTAG in the state operations manual that is related to the election statement, and that is LTAG 673. And this would direct the surveyors to look for signed copies of the Notice of Patient Rights and the election statement. And then 418.24 is referenced. It's not in the SOM, but it is referenced, and 418.24 addresses the content of the election statement and specifically the waiver of other benefits. And we'll be going through that, but that is what your surveyors will be looking for. Now, in CMS's instruction about the election statement, there is no particular form, just like the CTI, but the content of the election statement is prescribed, and we'll go through that. An election statement, I said earlier, is not the notice of election. It is also not your consents. Consents are what a patient signs when they're consenting to receiving care from your hospice. They're consenting to actually being assessed by your hospice, being charged by your hospice, allowing you to charge their insurance company. It's a legal document that supports you caring for the patient. In addition to that is the election statement. So they are two different things. And a patient signs an election statement, and it continues and remains in force until it is terminated. And there are only two things that can terminate that election statement. Either the hospice discharges the patient or the patient revokes. That's it. Those are the only two things that stop that. So an election statement can cover many benefit periods. Say the patient's on for 4 benefit periods before that patient revokes. There will be 1 election statement and 4 CTIs. And that's assuming there's, of course, if the patient doesn't die and you've got a live discharge at the end. A couple things about the discharges and the revocations. Only a patient can revoke. A hospice cannot say to the patient, you need to revoke. If the patient needs to revoke, or at least that's the opinion of the hospice, they need to discharge that patient. Patients are the only ones who can elect hospice care, and they are the only ones who can revoke that election. The hospice can discharge, but the hospice cannot revoke the patient. I know that it sounds like a matter of semantics, but I think we have to really be careful about that, because we've seen in documentation where clinicians will write, will tell the patient to revoke, will instruct the patient to revoke, will be revoking the patient. I've seen that actually written in the records. That's going to get hospices in trouble, so be very careful with that. So the content of the election statement, it has to include the following information: the name of the hospice that's going to provide care to the patient. That's oftentimes missing because I've seen purchased election statements and then the hospice doesn't add their logo and their name on there. Or there's a blank. I've actually seen purchased election statements where it says, I elect hospice care from, and there's a blank line, and the hospice hasn't filled it in. Make sure that your name is on there. Also required is the individual's or the legal representative's acknowledgement that they've been given a full understanding of hospice care, particularly the palliative rather than curative nature of the treatment. You do not need to explain in the election statement what palliative is versus curative, but it should be somewhere. Most of the time, I see it in admission packets over the course of several pieces of paper. It will be explained, or maybe there's even a booklet that explains it. All that's fine. What needs to be on the election statement is simply a statement that says, I acknowledge that I've been given a full understanding of hospice care, particularly the palliative rather than curative nature of treatment. But then you got to make sure you back that up and you actually do it. Okay, also required is the individual's or representative's acknowledgement that they understand that certain Medicare services are waived by the election. And I'm going to talk about that waiver in just a little bit here. I have some slides specific to that. But they have to acknowledge on the election statement that they understand that they are waiving certain Medicare rights. Also on the election statement is the effective date of the election. The effective date of the election is the date that the patient is signing that election statement or a future date. It is never a previous date. That is not allowed, and CMS specifically says that, which I've italicized here on slide 41. Fairly new in the election statement is the requirement that the individual's designated attending physician be identified. And again, this is a patient's choice. So in your election statement, there should be the designation of the attending physician, a separate sheet of paper identifying the physician, and attached to the election statement is okay. But a separate sheet of paper that does not state it is part of the election statement is not acceptable. So when you're looking at this election statement, you either have to make sure that, like the CTI, all the components are on one page, or the items that aren't are labeled as an addendum to the election statement, or it's election statement page 2 of 3. Whatever it is, I think you all understand what I'm saying here. We've got to make sure that it's clear to a reviewer that this is part of the election statement, and it does contain the individual's designated attending physician if they have one. They do not have to have an attending physician, and if a patient does not choose an attending physician, that does not mean that the medical director is automatically the physician. I know it feels that way. I know that the medical director has to take responsibility for the medical component of care for that patient when they don't have an attending, but technically, they have no attending, and it is not an automatic assignment. Okay, how is the attending physician identified? First of all, you want that physician's full name. CMS likes to see the MPI number of that physician. Well, patients aren't going to have the MPI number of their physician, and I discourage hospice staff members from writing all over the election statement. What I strongly encourage folks to do, if you're going to put that MPI number on there when you go back to the office, is have a little section on your election statement that says for office use, and then just have a box there for the MPI. Not required, just a suggestion. But you do have to have identified the patient's designated attending physician, or if they don't have one, have them indicate that they're not choosing one. There also has to be an acknowledgement that their attending physician was their choice. So there should be a separate statement that says, I acknowledge that I have the choice of my attending physician. And then, of course, you have to have the signature of the individual or the representative. Now, that's how the requirements are listed, and I want to talk about the signature before I get into the waiver. It specifically states signature. This is not a verbal statement. A signature is a signature, and that is required. So I've seen hospices obtain verbal consents over the phone, and those are verbal consents over the phone and a verbal election over the phone. You might be able to obtain verbal consents in your state. Your attorneys might advise you that that's fine. That is completely outside of the scope of what I'm talking about here. I'm talking just about the election statement. Cannot do that with the election statement. You can fax it or email it to a representative outside of the area, but you don't have a valid election until they actually sign it and get it back to you. There's no such thing as a verbal. Even if that verbal is witnessed by 2 other people, still doesn't count. So make sure that you actually have the signature of the individual or the representative. If the patient cannot sign, they are to make their mark. I think everybody who has been through nursing school or physicians, anybody working in the clinical healthcare arena knows that you can accept the mark of the patient, and then, of course, you want to identify that it is the mark of the patient. That is allowed. It is not acceptable if the patient is able to make his or her own decisions. They have to sign or make their mark. They cannot say, oh, I'm really tired, so they're going to have their daughter do it. CMS does not allow that, and I have on some occasions seen that denied. I think CMS is going to look more closely or instruct the MACs to look more closely at that in the future. So if the patient is unable to sign, we suggest that you document why the patient is unable to sign. If they've got Alzheimer's or something like that, I think it's pretty clear. But if they're able to make their own decisions and they're not signing, it should be because at the moment that you are there, they are not able to make their own decisions as determined by the person who's having them fill that out. But again, it has to be the signature of the patient. Okay, I do want to talk about the waiver real quickly here. The election statement has to contain the acknowledgement of the waiver. Okay, and this is a waiver of Medicare. And it's a waiver of traditional Medicare benefits. This does not apply in a Medicaid case. It does not apply in a non-Medicare, non-Medicaid case. When you have patients who are non-Medicare or non-Medicaid, they should not be signing this part of the election statement. They don't even have to have a Medicare election statement. Now, for a lot of different reasons, which I'm not going to get into here, we recommend that what you do with your election statements is that it states Medicare, and then for non-Medicare patients, you have a section specific to them that contains many of the items in the election statement but does not contain the waiver. For Medicaid patients, you usually have a separate election statement that they need to sign. Sometimes it's very similar to a Medicare one, but do not have a patient who is not Medicare sign the Medicare waiver. That really is not a valid election statement. Okay, so what the waiver is it states that an individual, by electing the Medicare hospice benefit, is waiving all of their rights to Medicare payments for the following services. Any hospice care that's provided by a hospice other than the one they're getting care from now, the one that they're choosing care from right now. That's why it's important to have your name on the election statement. So if another hospice is providing care to them too, that other hospice is not going to be paid. Now, another hospice can provide services to that patient if you designate that, if you contract with that other hospice to do so. And there's certain requirements governing when that might occur. For the duration of hospice care, they also waive their right to any Medicare services that are related to the treatment of the terminal condition for which hospice care is elected, or any related condition, or services that are equivalent to hospice care. So that's hospice care by another provider, services that a hospice should be providing. Let's take aid services, for instance. I will often see a hospice say, we only provide aid services twice a week, or I'm short aids, I don't have anybody to provide them. But this patient also receives aid services from Medicaid, so I'm not going to worry about it. Not allowed. You're required to provide aid services in the amount that the patient needs. Now, that doesn't mean staying in the patient's home for long-term care like a lot of the shift care is. But it does mean that you have to provide aid services that are necessary for the palliation and management of that patient's terminal illness and related conditions, and the other services or other aid services provided by somebody else will not be paid, should not be paid. Oftentimes they are, but later on that becomes a problem. So I use that example for a couple of different reasons. One, want to stress that we are required to provide certain services, and those are listed in the Medicare Benefit Policy Manual, and it's more than just what core services are. Okay, and that's all listed there. Also, we are required to not, I'm going to back up a second and say this a little bit differently. We are required to explain this waiver to the patient, and that means that we need to understand it. So we need to understand that the patient should not be receiving services from any other provider if those services are related to the patient's terminal condition or related conditions. And we really are responsible for clearly explaining that to the patient. They can receive services from another provider if you arrange for it. The hospice is the manager of this patient's plan of care, and they should not be going outside of that. And that's really the purpose of explaining this waiver to the patient, because it will help you later on. If they go to the emergency room without notifying you, you can come back to this waiver and say, remember here, you waived your rights to those Medicare payments because that service is related to the terminal illness, and I didn't provide it. I'm your designated hospice, and I did not provide that. I did not arrange for another hospice to provide it, nor did I arrange for that hospital to provide it. So technically, you're responsible. It cannot be billed to Medicare. This waiver will actually help you, so you do want to explain that. But you can see that last bullet point here, which I haven't talked about on slide 45, is that the individual's attending physician can be paid if that physician is not an employee of your hospice. Okay, so some common problems with the election statement are that it does not contain the name of the hospice, also doesn't contain whether or not this is a Medicare or non-Medicare patient. You want that to be specified. We want it to be clear that this is Medicare. The waiver information is not present. Sometimes the acknowledgement is not present. You do not have to explain the waiver on the election statement. You can explain it in another document, but the acknowledgement must be present on the election statement. Identification of the attending physician needs to be there and often is not. The acknowledgement of the palliative nature of hospice care, the OIG identified as missing, and then there are problems with the signature. Don't forget, this is the signature of the patient or the legal representative. So if the legal representative is the daughter, but the wife signs, you don't have a valid election statement. Okay, notice of election. And as we go through the rest of the slides, this should be fairly quick. These are pretty straightforward. The notice of election is prescribed by CMS for us to enter information into their system so that they're notified the patient is electing hospice services. It is not the election statement. The NOE must be filed timely, and that is 5 calendar days after the hospice admission date. Not only does it need to be filed, but it needs to be accepted. And how does a hospice know if it's accepted by CMS or not? Well, if it's not RTP'd. Well, that's not very helpful, because sometimes it's not RTP'd for 9 days, and you've already passed your 5-day mark. So this is and has been a big issue for hospices. Most hospices have gotten used to it now, but newer hospices do sometimes still struggle with this, or hospices still struggle with it for a variety of reasons. So what we suggest here is a very solid process where the NOE is being submitted the day that that patient is admitted, and that somebody is checking daily to see if it's been accepted by Medicare. Now, very recently, CMS has allowed the NOEs to be submitted electronically, and this is a big distinction. Electronic submission of the NOE means that when the information is being entered, the system is looking and checking databases simultaneously, and if it sees, for instance, that the Social Security number, the birth date of the patient doesn't match this patient's name, it's going to give you an edit that says, well, wait, stop, there's a problem. You can fix it immediately and still get your NOE submitted. Without electronic processing, it takes days for CMS systems to do that checking. So you're not notified usually within that 5-day time frame that there's an issue. That's why we want electronic processing. Let us know right away there's a problem. What electronic processing does not fix is if a hospice enters the wrong start of care date. The system doesn't know it's wrong, of course, so you have to make sure that you are entering information correctly. But in recent months, CMS did release what is called a change request, a CR. The number is here, and this gives instructions to the MACs for accepting the notices of election electronically. And this is voluntary. You can still submit via DDE, but you can submit voluntarily right now the NOE if you're submitting to NGS. And here's what's going on right now, and this is fairly new. So I've added this into the presentation here. When CMS sent out this change request in the instructions to the MACs, they left off part of the instructions. And the missing piece is that in the electronic submission, there's a certain line item, requires a Q code, and it's Q code 5009 that needs to be on there, and that requires in the Medicare system a description. The suggested description is just the letters NOE. But CMS did not provide the instruction that you have to have that description. A lot of the EMRs don't have it. And there's some processing problems within the MACs with that. So both Palmetto and CGS have said, hold up, instead of trying to submit electronically, even if you've got the descriptor, we're still having problems. Stop, go back to doing DDE. We'll let you know when you can electronically submit the NOE. NGS, and NGS only, has said they have a workaround. If your EMR has done it right, and if there is a description next to that Q509 or 5009, you can submit to NGS, and NGS will manually override. So hopefully that's clear to everybody. If you're not NGS, you should not be doing electronic processing right now. That will eventually get fixed. And I've provided you on slide 51 some additional information about that change request because it actually updated the claims processing manual, and there's a lot of information in there that's not, in my opinion, really even related to the NOE. And it talks about the corrections to the admission date and what needs to be done if you're going to correct that. So make sure you go ahead and still read that CR for these other changes as well. Okay, now there are some exceptions to timely filing. This is pretty much catastrophic situations, natural events, and it has to be something that is beyond the control of the hospice. So that's why I'm talking about these natural events, natural crises, or some sort of civil disturbance or something like that. It is not because all of your staff are out because they all got the flu. That is not an exceptional circumstance. CMS would expect that you would be prepared for that. Now, if you're a newly Medicare certified hospice and you have some questions about this, please talk to me after the presentation today. So if you do not file your NOE timely, there are some requirements. First of all, you're still liable for those days. You still have to care for the patient at no charge. And there's an occurrence SMAN code that must be used on the claim to indicate the days that are non-covered, and that is a code 77. And then a KX modifier needs to be added to the claim with an explanation of what occurred. And if your NOE is denied, you can appeal that denial. The biggest issue really is when the hospice does not have the correct start of care date and the KX modifier is used, but the explanation just really isn't clear enough to the MAC to allow the claim to go through. So in addition to notifying CMS of an election, we also have to notify CMS of terminations and revocations. That's the NOTR, same concept. You have to submit that to CMS within 5 days after the patient's live discharge. If the patient dies, you don't have to do that. You don't have to submit an NOTR if the final claim is filed within that 5-day time frame, because on the final claim is the code that identifies that this patient has had their election terminated or they've revoked. So there's no consequence at this time if you don't do your NOTR timely. However, what's happening is a patient will revoke, so an NOTR needs to be done. They'll go and get some treatment or services and come back a couple of days later to the same hospice. Same hospice goes and sends in the NOE. NOE is denied because the NOTR hasn't been processed. And in the KX modifier, then CMS or the hospice will indicate, well, the NOTR from the previous hospice stay had not processed yet. CMS will deny if that NOTR is from the same hospice. So if the same hospice who the patient revoked from is now admitting the patient, and they could do a notice of election, surely they can process an NOTR, is how CMS is looking at that. So that's really the biggest issue I hear still about the NOTRs, and the same for exceptions apply. Now, some common problems with NOEs and NOTRs is, of course, timely submission, the situation I just talked about, the discharge and revocation, and the start of care date. And the final item that is required for a claim to be paid is the plan of care. Now, it says this in the Medicare manual, and CMS contractors are not going to look at that plan of care in the same way that a surveyor would. They're looking to make sure that a plan of care is in existence. They have said, as with any election, the hospice must fulfill all other admission requirements, such as cert or recert, any required face-to-face encounters, or conditional participation assessments. Now, what they're going to look at here, like I said, on the plan of care is to make sure that it exists. That means it has to be labeled, easily identifiable, and it contains all of the required components. And those required components are listed partly in the Medicare manual, the ones that state that services have to be consistent with the plan of care is stated there. They also state that the plan of care must be established before hospice care is provided. Well, wait, what? How can we do that? What that means is that CMS expects that the plan of care is going to be initiated based on the information that is gathered in that patient's initial assessment, and then you develop the plan of care from there. So in many hospices' views, we are caring for the patient the time we go out there and admit them before that assessment is even completed. CMS doesn't look at it that way. They say that the plan of care has to be established before hospice care is provided. So they're looking at giving you that assessment period. This does not have to be done before the patient's admitted, which is sometimes the way it sounds to folks. Okay, services have to be consistent with the plan of care. And here's what the MACs are really looking for in this review, and what I really think is going to be a problem with TP, because we've seen it be a problem with the CERT. The plan of care has to be developed and periodically reviewed by the entire IDG in consultation with the attending physician if there is one. That has to be clear in the record. And if it's not, CMS will, or the MACs will deny. So make sure on 559, you're looking at that last bullet point, that the plan of care clearly is developed by the entire IDG. This does not mean that the entire IDG has to sign that plan of care. And when I say IDG, I'm talking the 4 core components. Volunteer coordinators don't need to sign. Bereavement coordinators don't need to sign. You need a physician, an RN, master's prepared social worker, and a pastoral counselor or other counselor to sign that. Those are your core disciplines. And they have to either sign that plan of care as an indication that they've all been involved in that plan of care at the time it was developed and the time it was reviewed, or you can have other documents that show that all 4 core disciplines were involved along with the attending physician if there is one. And that communication from the RN or your hospice physician that occurs with the attending physician is acceptable. The attending physician does not have to come to an IDG meeting. They can communicate with other members of the IDG, and that's how they can show, or how you can show involvement of the attending physician. There has been a major problem with some of the reviewers not seeing signed plans of care. And this in particular occurred with some CERT reviews. The reviewers were requesting the IDG sign-in sheet and agenda. Well, we've talked to two of the MACs about that. That is not proof that the plan of care was developed or reviewed by these IDG members. All that's proof of is that you had a meeting, these people attended, and these patients were discussed. This information that shows that the plan of care was developed and reviewed by these core members should be part of the medical record. The agenda and sign-in sheet don't do it. Now, I know some CERT reviewers were requesting it, quite a few. I know they approved the claim with that information, but that is probably not something that's going to happen on TPE, so don't count on that if you were one of those hospices, okay? Just make sure that you've got narratives, you've got signatures, something that shows that all these people were involved, because that is the biggest problem with the plan of care. Now, in the next couple of slides, what I've done is provide additional information that's in the SOM about what has to be on the plan of care. And typically, the MACs aren't going into a lot of detail reviewing this because it's just too long and they're looking to surveyors to do that, but technically it's listed there. Now, some common problems with the plan of care are that they can't find it in the record or they can't find all the components. There will be something marked plan of care, 485, and the medication list, which is supposed to be part of the plan of care, isn't there. Or it's in another part of the record, and it's not marked as being part of this plan of care. So make sure all the components are there. They're easily identifiable. The biggest issue is that the plan of care does not cover all the dates being reviewed. That the plan of care submitted is not for the same time period that is being reviewed, because sometimes that time period overlaps two different plan of care documents. Make sure both are included. And I think those are the biggest issues. Okay, a couple of words on targeted probe and educate, and I know I'm right at the end of my time here, so I'll just say this quickly and then I will open it up for questions. We've done a lot of coverage of targeted probe and educate. If you're not familiar with it, please go to our blog. Please look at the previous webinar that Melinda did on targeted probe and educate. It applies to hospice and home health agencies. The same rules apply to both. What is going to be different is the topics that CMS and the MACs have chosen for review. Currently, for hospice targeted probe and educate, only CGS has published what they're going to be looking at. Palmetto has told us that they will probably publish within sometime this year. They're not expecting to do that immediately. They've not chosen any topics right now, okay? So Palmetto doesn't have anything going on right now with hospices to our knowledge. They don't have anything posted, and they've told us it's not going to be until sometime in 2018. They did not specify when, but we're constantly looking. It is entirely possible that you might receive a letter about targeted probe and educate, and you can see on slide 64 that, slide 63, that there are certain requirements of targeted probe and educate, and that you will, as part of that, receive a letter notifying you that you are under a probe and educate. You will receive that from your MAC. It is possible that you'll receive that letter before we see Palmetto post anything or before we see NGS post anything. If that happens, call us and we can assist you through that process. But we're constantly looking on the Palmetto and NGS website for their publication. CGS has published that they're going to look at hospices claims with length of stays with non-oncological diagnoses when they are greater than 730 days. That's a long length of stay. This makes sense. The length of stay in a long-term care, nursing facility, or SNF, they're looking here at those Q5003 and 5004 codes with length of stay greater than 180 days. We believe that NGS and Palmetto will also look at length of stay. NGS has verbally said they will look at GIP length of stay, but they haven't officially formally published that yet. So we're, again, looking at that. But these are the areas that are going to be the focus of the targeted probe and educate, but your CTIs, your election statements, NOEs, and plans of care still all need to be present. So we get the question all the time about what other areas could fall under targeted probe and educate. It really can be anything. It's going to be based on data. If these MACs have done some data mining in the past, and if the hospices that fall outside the norm, either above the average or below the average, they could target those hospices and identify those particular areas. So it could be anything. But targeted probe and educate is supposed to focus on areas where Medicare payments are most vulnerable. And we already have those target areas that CMS has identified through our PEPR. So I've provided you on slide 65 other potential areas where the MACs might go for target areas for targeted probe and educate. But again, we don't know. They can choose them, and it can be these areas. It can be any other area they select as long as they have data that shows most hospices fall within a certain norm, and there are outlying hospices, and it's the outliers that are going to be targeted. Okay, so some resources for you on everything that we've talked about today are, of course, the Benefit Policy Manual. That's Chapter 9. The State Operations Manual, Appendix M, those 2 MLN articles, and if you are an HPS Alliance member, we do have for you CTI audit tools and election statement audit tools. Now, I know I went slightly over on my time, but I am going to go ahead and open this up for questions if anybody has any. So I will do that now. Sorry, it's going to take me just a minute here. So I've opened it up for the Q&A session. If you would like to ask a question, please choose *6 on your telephone pad, and you can go ahead and ask now. Again, if you have any questions, go ahead and hit *6 on your telephone pad. And since I haven't heard anybody, I'm going to go ahead and close out our webinar today. You can submit questions via email, and my email is on the very last slide and the very first slide of the presentation today. I do appreciate your extra attention. I know I took a couple minutes over, but it was important information. I hope you all have a good start to 2018, and we will talk with you soon. Take care.